And whenever we look at a ECG, the first thing that we look at is the rate. ठीक है, चाहे वो आप tachycardia के algorithm देख रहे हो या normal ECG देख रहे हो, the first thing is look at the rate, and I'm talking about ventricular rate first because सारे algorithm tachycardia के QRS की rate से शुरू होते हैं. ठीक है, for tachycardia rate 3 second or 6 second strip is important ताकि आपको एक exact number मिले. Average around this is not the answer. So 3 second or 6 second strip के ऊपर ventricular rate को count करने के बाद, when you have decided this is a tachycardia, then the next question that you ask yourself is the QRS duration less than or equal to 120 or more than 120? So that is the second question that you need to answer, because आपकी सारी differential diagnosis tachycardia की divided है narrow complex और wide complex tachycardia के अंदर. I'm not talking about कि ये SVT है या VT है या Berency. I'm only talking about narrow and broad QRS tachycardia that is on the ECG. So we talk about narrow complex tachycardia. We have a list of at least 7 differential diagnoses. Take it right from to AVRT. So 7 possible differential diagnoses of a narrow complex tachycardia. अब इसमें से कौन सा वाला है? You will have to, dig into that big box कि इसमें से क्या है. So it can be AVNRT, AVRT, atrial tachycardia, sinus tachycardia, flutter, fibrillation, MAT. How would you? This is a long list, and looking at a 12-lead ECG, so it is convenient to divide or classify a narrow complex tachycardia based on whether the QRS is regular or irregular. That makes your life a little easier, and the differential diagnosis the list becomes shorter. So in a regular narrow complex tachycardia, you have only possible 4 differential diagnoses: AVNRT, orthodromic AVRT, atrial tachycardia, sinus tachycardia. ठीक है, इसमें junctional tachycardia भी आ जाता है, इसमें PGRT भी आ जाता है. These are less common causes, but they are all regular narrow complex tachycardia. जो irregular narrow complex tachycardia है, there are only 3 possible causes.
तो हमारे उस पे भी नाम आ गए हैदराबाद. अच्छा चलो ठीक. आईडी में हैदराबाद लिखना चाहिए ना आप लोगों को. वीडियो पे नहीं आ रही.
Okay. So when you divide your narrow complex tachycardia into 2 broad categories of regular or irregular, your differential diagnosis becomes shorter and your life becomes easier. If you are dealing with an irregular tachycardia, you have only 3 possible differential diagnoses. And when you're dealing with regular narrow complex tachycardia, they're only dealing with at least possible 4 differential diagnoses. So this is an algorithm from American Heart Association Guidelines 2003. This is an absolutely wonderful algorithm, and it starts with narrow complex tachycardia, whether it's regular or irregular. And if the answer is it's not regular, it comes down to 3 differential diagnoses: AFib, atrial tachycardia with variable AV conduction, and MAT. And I'm not going to use the word flutter very commonly here. All tachycardias, whether atrial tachycardia, focal, or flutter, they are all atrial tachycardia. So please use the word atrial tachycardia to avoid any confusion. Now, this is an ECG where this is irregular, narrow complex tachycardia, right? And this is what we say is atrial fibrillation. This is another example where you see irregular, narrow complex tachycardia, right? So how does the ECG in atrial fibrillation looks like? This is important because a lot of you guys mistakenly label ECGs where there is sinus rhythm or PACs as atrial fibrillation. The hallmark of ECG in atrial fibrillation is there are no P waves. And the ventricular rate is completely bizarre, irregular. There are no two QRS complexes which are identical to each other. So there, and then the baseline has a fibrillatory, very fine, minute oscillation waves. And they are not P waves, and they do not match to each other. The rate of fibrillation actually varies between 300 to 600 beats per minute. And sometimes what happens is if you look at in lead V1, which is a lead which sits right on top of the right atrial appendage, sometimes large F waves can be visualized, and you may say this is a flutter wave. It cannot happen that there is flutter in the V1 and there are fine atrial fibrillation in the rest of the 12 lead ECGs. So be very careful when you're actually calling flutter or fibrillation. So limb leads are the leads that give you the best fibrillatory waves. P1 will give you large F waves, but they do not match to each other if they are in fibrillation. In tachycardia or in atrial flutters, they match each other. Take it. So iske andar, if you look at this ECG, they are so fine, minute, and they may seem P waves here sometimes, but they do not match to each other. None of the P waves are matching to each other. Sometimes what happens is the atrial fibrillation is so fast that it appears to be regular. And I'm saying appears to be regular because that is what you eyeball. देखिए शायद ये regular लग रहा है, but there's nothing as shayad or probably. You have to measure the RR interval. Sometimes you have to increase the paper speed, measure your RR interval to prove that this is atrial fibrillation, because the ball game changes everything. The diagnosis changes everything. So sometimes fibrillation may appear regular. Then the next differential diagnosis for irregular narrow complex tachycardia is atrial tachycardia with variable AV conduction. And what is atrial tachycardia? We know that atrial tachycardia is a atrial rate more than 100 beats per minute. The P waves are constant, morphologically identical to each other, and they fall outside the sinus node. So atrial tachycardia is not sinus tachycardia. Any P wave coming outside the sinus node is an atrial rhythm, right? The current classification of atrial tachycardia is based on its mechanism. And it can be either macro reentrant atrial tachycardia or it can be focal atrial tachycardia. This is how you describe in atrial tachycardia, whether this is macro reentrant or this is focal atrial tachycardia. Unfortunately, a lot of cardiologists and general physicians are still using flutter and atrial tachycardia because they don't know that the guidelines have actually changed. It is a mechanism, and you may not be able to distinguish the mechanism on just a 12 lead ECG. The history and sometimes EP study in entrainment will tell you. There is more on history than on ECG. Okay, so previously ECG discrimination was used to differentiate flutter and atrial tachycardia, right? And this was based on two things: rate and presence of isoelectric line. इससे ज़्यादा है या इससे कम है तो ये 80 है, इसमें ये isoelectric line है तो ये flutter है, इसमें नहीं है तो ये atrial tachycardia. This classification is now obsolete. Because the classic definition of flutter being more than 240 with isoelectric line and atrial tachycardia less than 250 beats per minute with presence of isoelectric line may or may not happen every time, right? There may be times when atrial flutter patient is on medications and the atrial tachycardia rate goes to 200 or 210 or 190. And there may be isoelectric line because of so diseased atrium that there is stretch of isoelectric lines in between. So that may not hold true. Sometimes atrial tachycardia in a very young, healthy, young patient may be so fast that they may appear that there was no isoelectric line in between, and the rate may go as high as 290 or 300 beats per minute. So understand that there is no ECG classification of atrial tachycardia or atrial flutter. We talk about mechanism. Focal, usually in structurally normal hearts. Flutters, which are macro-reentrant, usually in structurally abnormal hearts. Okay. So this is a 12-lead ECG for you all. And you see this is tachycardia. Obviously, the first thing that you will see, this is narrow complex. And you see that there is regular, and then it becomes irregular in between, and then regular. So it is not bizarre. It is not completely irregularly irregular, and so it does not fall into fibrillation, right? And you do see P waves, right? And here in all the leads. So for convenience sake, by the algorithm, this is a narrow complex, irregular tachycardia, regularly irregular, and this is atrial tachycardia with variable AV conduction. Okay. Now, the second thing that you can comment on when looking at a 12-lead ECG is where the P wave is coming from or the tachycardia is coming from, right? If you can't comment on whether it's focal or macro-reentrant, the one thing that you can comment is where is it coming from, right or left? And for assessing whether the tachycardia, atrial tachycardia is coming from right or left, you have to look at 6 possible leads. You have to look at inferior leads, you have to look at V1 and the lateral leads 1 and AVL. Over the years, I have learned from my mentors that the rule of concordance holds true for most of the tachycardia, right? For the concordance, you have to look at P waves in inferior leads and P wave in V1. Concordance mean the morphology of P wave in all these leads are similar, going in the same direction. Or it can be all positive or it can be all negative, right? So if P wave is positive in inferior leads and V1, this is usually a left-sided tachycardia. And the rule of discordance is if there is opposite polarities, V1 is positive and inferior lead is negative, or vice versa, this is a right-sided tachycardia. So whether the P wave is all positive or all negative in inferior and V1, this is left-sided. If it is discordant, means positive in one and negative in the other, or negative in one and positive in the other, is a right-sided tachycardia. Negative AVL is usually a left-sided tachycardia, right? So that is the only thing that you can comment on the origin, and that will tell you some more about the patient's tachycardia, but history comes in handy, right? So when you talk about atrial tachycardia, obviously focal atrial tachycardia can have only so many areas of origin. Right side में young structurally normal heart के अंदर you can have crista terminalis, perinodal tissues, coronary sinus ostium, tricuspid valve annulus, right atrial appendage. ये सारी leads के अंदर P wave discordant होंगी inferior leads के अंदर. And left side के अंदर pulmonary veins हैं, mitral valve है, लेफ्ट एट्रियल अपेंडेज है. ये फोकल एरियाज है जहां से एक फोकल ऑटोमेटिक टैकीकार्डिया निकल सकता है. ठीक है, these are structurally normal heart. Then when you talk about flutter, which is a macro reentrant atrial tachycardia, and as the name says macro reentrant, it means there has to be an area of slow and fast conduction, so it has to be a circuit, and for a circuit there has to be slow and fast. So atrial flutter जो कि right sided flutters होते हैं, जो कि common flutters होते हैं, जिसको classic flutters कहते हैं, जो sawtooth appearance देते हैं, they have a re-entry around the tricuspid valve, right? So right sided tricuspid valve के around, they can have one direction or the other direction re-entry. Cavo-tricuspid isthmus is an area of slow conduction. The rest of the atrium is fast. अगर किसी का atrium बहुत ज़्यादा diseased होगा, the rest of the conduction will also become slow and there will be no sawtooth appearance. ठीक है, so do not go on only on sawtooth appearance. The re-entry, जो flutters, जो left-sided या atypical flutters जिनको कहते हैं, they have macro re-entry around the left side, usually post-surgery, post-ablation. उसके अंदर mitral valve के around हो सकता है, surgical scars के around हो सकता है. So that the history will tell you okay, this is a left-sided macro re-entrant tachycardia and not a focal atrial tachycardia. Somebody had atrial fibrillation prior surgery, mitral valve की हो गई थी, and now they have this atrial tachycardia. It's a left-sided macro reentrant atrial tachycardia. You cannot have a focal atrial tachycardia in a diseased heart, जहाँ पे बहुत सारी slow or fast conduction हो सकती है. So atrial flutter is a macro reentrant atrial tachycardia. So sometimes it is very easy to identify a classical flutter if it is in a heart which is not too diseased and the patient is not on medications. Take it, the classic counterclockwise has positive V1 and negative inferior leads, and the clockwise is just the opposite. If you look here, you have this classic sawtooth in the inferior leads and positive V1. And this is a classic clockwise where you have positive P in V1 and negative, positive in inferior leads and negative in V1, right? So this patient has not been on medications. That is why you see a classic flutter. Patients are on medications, the classic flutter की शक्ल बिल्कुल change हो जाती है and you cannot diagnose flutter. You just say this is an atrial tachycardia coming from the right or the left side. So, so if we go over this ECG, where is this coming from? This is an irregular tachycardia. It's an atrial tachycardia with variable AV conduction. The lead 3, 2, and AVF are negative. V1 is positive. So you have to follow. This is the P wave in V1, and if you follow it down, this is negative in lead 2. So this is discordant P wave, and this is a right-sided atrial tachycardia. If you say that this is a right-sided atrial tachycardia, this is more than enough. But since it is an untouched atrial tachycardia without medications, you see a classic flutter image. So it's a counterclockwise CTI dependent right-sided flutter, right? Then this is another ECG. This is also a diseased heart. You can see P waves identified in lead V1. This is irregular, but not irregularly irregular. You see P waves, small, minute P waves here, but they are identical. This is positive in V1 and positive in lead 2. So this is concordant. So this is a left-sided tachycardia. This patient had a history of atrial fibrillation, underwent atrial fibrillation ablation, and later on developed a roof-dependent tachycardia. So this is a macro re-entrant tachycardia in a post-ablation patient, right? The rate is not 250 as the classic teaching of atrial flutter is. This is 220, right? So this does not hold true. There is no absence of isoelectric line. There is isoelectric line in between, right? If you see here, there is an isoelectric line. This is not a sawtooth appearance. So this is also against your ECG classification of flutter, but this is actually a flutter, right? Because that was proved mechanistically. So this is an atrial tachycardia, left side atrial tachycardia in a post-AF patient. The third is a multifocal atrial tachycardia. Obviously, as the name says, more than one P wave morphology in a narrow complex irregular tachycardia. Their variable PP, variable PR interval, this is not atrial fibrillation because you will see P waves. And this is also not just sinus rhythm and PACs, right? You will see an irregular tachycardia. So if you see here, this patient has sinus rhythm, one PAC here, which is negative in inferior leads, and then you have a short run of tachycardia, right? In this tachycardia, this is one P, this is the other P, this is the other P, right? So three different morphologies of P waves in a slightly irregular tachycardia. This is a multifocal atrial tachycardia. Again, Another ECG, you have sinus rhythm, PAC, another PAC. So these are PACs, but this is a run of irregular narrow complex tachycardia where you have one P wave, one P wave. So you have at least 3 different morphologies of P wave. The PP interval is different, the RR interval is different, but this is not completely irregular. So this is not AFib, this is MAT. We usually don't see MAT in cardiology practice a lot. We usually see this in more in ICU settings. Now, switching gears from irregular narrow complex tachycardia to now narrow complex regular tachycardia. I would ask my participants from Bhavalpur and Dr. Kashif's fellows, if they have any questions, please unmute yourself and you can ask. We have about 30 seconds to move on. Any questions? Okay, so I'm going to mute everybody and I'm going to move on to the next part of this session where we will talk about narrow complex regular tachycardia. And we have 4 fundamental rules of reading an ECG with a narrow complex regular tachycardia. All right, is to look for P waves, presence and number of P waves. You have to analyze the RP and the PR interval. When you are in a tachycardia, you can only analyze the presence and number of P waves and the RP and the PR interval. But if you have an opportunity to see the onset of a tachycardia, especially when somebody is on a telemetry monitoring or if somebody has a Holter monitoring, you can see how the tachycardia starts and the mode of termination, right? So you may see a mode of termination spontaneously, or you may use some maneuvers or drugs to terminate the tachycardia. That will also help you, right? So this is again the same algorithm where we started with narrow complex tachycardia, regular, and when we say visible P waves, right? And you say, yes, we have P waves because this is regular. Then the second question you ask yourself is, do we see more P waves or equal number of P waves to the QRS? If you have more P waves than QRS, this is atrial tachycardia unless proven otherwise. And this atrial tachycardia can be anything, focal or macro reentrant. Right, so in a regular narrow complex tachycardia, when you see P waves and the P waves are more than QRSs, that is an atrial tachycardia, right? And this is an example of a regular narrow complex tachycardia where you see 2 P waves to each QRS. There's one P wave which is sitting before the QRS and one is sitting in the end of the QRS, giving it a beaked appearance of the QRS. And so all these P waves march and there is a regular association to the QRS. So this is 2-to-1 atrial tachycardia. This is in AV conduction. This is not an AV block. Please use proper words when you're describing a tachycardia. This is 2-to-1 atrial tachycardia. This is atrial tachycardia with 2-to-1 AV conduction. It can be 3-to-1 AV conduction. It can be 4-to-1 AV conduction. It's not a block. Okay. Again, this is another ECG. This is also a regular narrow complex tachycardia, right? And you move on to the algorithm, you look for P waves. Do you see P waves? Yes, you see P wave right hidden in the QRS and you see a P wave in the T wave. Okay, so who has raised their hands? Okay. So this by rule is a what? Is a 2-to-1 atrial tachycardia. So atrial tachycardia with 2:1 AV conduction. That is what you can say on this 12-beat ECG. The P wave is positive in lead V1. It is negative in lead 2. This is a discordant P wave morphology suggesting this tachycardia is coming from the right side. So right-sided atrial tachycardia with 2:1 AV conduction. Right. Again, the same rule apply. Origin of the atrial tachycardia that we've already talked about. So this patient has positive P wave in V1, positive P wave in lead 2. So this is a left-sided atrial tachycardia with 2:1 AV conduction. Okay. This we've already talked about. So right-sided atrial tachycardia, 2:1 with a 2:1 AV conduction. This is another tachycardia. You see variable AV conduction. P wave is negative in V1 and positive in lead 2. This is also discordant. And where is this tachycardia coming from? This is a right-sided atrial tachycardia, right? So this is a right-sided atrial tachycardia with 2:1 and 3:1 AV conduction. Now, then again moving to the next limb is once you have a P wave, which is exactly equal to the QRS, no more P waves, but only 1-to-1 QRS and P wave, then you have to analyze the RP interval, and then the differential diagnoses are based on the RP interval, right? So अगर 1-to-1 AV tach 1-to-1 tachycardia है, atrial fibrillation MAT, atrial tachycardia with variable AV conduction, or atrial tachycardia with 2-to-1 AV conduction is completely out. What you're left with, AV RT, AV RT, sinus tachycardia, and atrial tachycardia, focal atrial tachycardia, right? You're left with all 4 of these diagnoses. So short RP and long RP decides which is the most likely diagnosis in that particular patient. So how do you analyze the RP and PR interval? फर्स्ट हम डिसाइड कर लेते हैं कि शॉर्ट आरपी में हम क्या सोचेंगे और लॉन्ग आरपी में हम क्या सोचेंगे, ठीक है, डिफरेंशियल डायग्नोसिस में। अब जो रह गए हैं वो एवीएनआरटी, एवीआरटी और एट्रियल टैकीकार्डिया और साइनस टैकीकार्डिया ही रह गए हैं, ठीक है। सो रेगुलर शॉर्ट आरपी के अंदर सबसे कॉमन इज AVNRT, the typical AVNRT. Then we have orthodromic AVRT, atrial tachycardia with first degree AV block as a third option. And I've not included junctional ectopic tachycardia in this because it's a very rare diagnosis, usually seen in young children. Long RP के अंदर the most common is atrial tachycardia, followed by atypical AVNRT. ठीक है, तो अगर long RP है तो आपको orthodromic AVRT कम से कम हो जाता है, ठीक है। PJRT is a form of clinical diagnosis where the pathway is retrogradely conducting and decremental. That is why there's long RP. Normally, accessory pathways don't do that. So they are all short RP tachycardias. Orthodromic AVRTs are short RP tachycardias. PJRT is a different type of tachycardia. Clinical diagnosis है, बच्चों के अंदर होती है, ये accessory pathway related tachycardia होता है. But for adult cardiology, atrial tachycardia and atypical AVNRT are 2 common differential diagnoses of a long RP tachycardia. ठीक है, and sinus tachycardia of course is a long RP tachycardia. How do you measure PR and RP? ठीक है, so PR, P to R क्या है? Atrium to the ventricle, और RP क्या है? Ventricle to the atrium, ठीक है। So and this is a ratio. PR ज़्यादा है या RP ज़्यादा है? There is no number. There's the number that we say कि 90 milliseconds is 70 milliseconds is to further differentiate AVNRT and AVRT, which it may not be very important clinically when you're dealing with a patient in the emergency room. The only thing that you need to know is it short or long, ठीक है। So short and long is based on the ratio. PR अगर एक patient का R to R interval is 200 milliseconds and RP is 80 and PR is 120, तो क्या हुआ? Short RP हुआ. एक का RP is 90 और PR is 110, तो क्या हुआ? Still a short RP because it's a ratio. It's a difference between PR and RP. ठीक है, so short RP we've talked about कि typical AVN RTs common होते हैं, junctional tachycardia, AVRT and atrial tachycardia. So short RPs, AVN RT, AVRT, atrial tachycardia with first degree AV block. यही तीन differential diagnosis common होती हैं. अच्छा, इसके अंदर कैसे क्या नजर आता है? So retrograde P wave is what you actually look for in a short RP tachycardia. Okay? And the P waves in a narrow complex regular short RP tachycardia or RP tachycardia is hidden in the QRS, at the end of the QRS or within the QRS. So like a little small blip. Or जो ये long PR conduction hai, this is going over the slow pathway of the AV node which has a slow conduction. तो कछुए की तरह वो घूमता घूमता पहुंचता है. And then when the tachycardia is on, the ventricle and the atrium activate simultaneously via a fast pathway. So VNA becomes simultaneous activation, and that is why the RP is very, very short. Okay? So goes through the slow pathway, up the fast, slow pathway, fast pathway up, slow pathway down, fast pathway up. This is how it's actually gonna do a circuit. AVRT के अंदर it is not simultaneous, it is parallel or sequential activation, right? Sequential means A, node, V, pathway, atrium. Okay, so V to atrium via pathway is going to be a little longer than simultaneous activation of VNA in AVNRT. ठीक है, समझ आ रही है कि उसके अंदर वेरी शॉर्ट क्यों नहीं होगा? क्योंकि ये सीक्वेंस है, पहले एट्रियम, AV node, ventricle, pathway, फिर atrium. So it makes a circuit, and the V to A is slightly longer than the AVNRT, जिसमें simultaneous V और A activate हो जाता है, but still a short RP tachycardia. ठीक है, so this is how a short RP orthodromic will look like. All re-entrant tachycardias will have negative P wave in inferior leads. Means it's retrogradely activating. So this is a classic narrow complex regular 1-to-1 AV conduction, and a short RP. You'll see a pseudo R and a pseudo S pattern here, which is a short RP tachycardia. Okay? Then लॉन्ग आरपी टैकीकार्डिया के अंदर कॉमनली हमने बात की एट्रियल टैकीकार्डिया होगा, एवी एनआरटी जो कि रिवर्स डायरेक्शन में होगा, और साइनस टैकीकार्डिया हो सकता है. ठीक है, सो इसमें क्या है, एट्रियल टैकीकार्डिया में पी वेव ऊपर से आएगी और वेंट्रिकल में जाएगी, एक एक पी वेव आएगी और एक एक क्यूआरएस को प्रोड्यूस करेगी. दिस इज नॉट री एंट्री. ठीक है, सो दिस इज 1-to-1, ऊपर से नीचे, सो दिस इज एन एट्रियल टैकीकार्डिया. और इसके अंदर आरपी क्या है, लॉन्ग है. ठीक है, एंड पीआर क्या है, शॉर्ट है. एवीएनआरटी के अंदर क्या रिलेशनशिप होगी? अभी हमने टिपिकल एवीएनआरटी की बात की थी. इट गोज थ्रू द स्लो पाथवे antegradally and very quickly up the fast pathway, giving a very short RP. If you make it reverse, if it goes through the fast pathway antegradally and retrogradely it goes through a slower pathway, the RP is going to be long. Okay, so this is how it's going to look like. This is an AVN RT with a reverse node pathways activation. So long RP, right? So यहाँ तक समझ में आ रही है कि how do you look for RP and PR, and this is in a 12 lead ECG where when the patient is in tachycardia, and that is how it will help you whether this is what type of tachycardia is going to be the most likely diagnosis. Okay, then the mode of onset is helpful, especially if you look at a telemetry or a Holter monitoring. Sudden onset versus gradual warming up. Gradual onset is sinus tachycardia or junctional rhythm. Sudden onset, एक पहले sinus चल रही थी, अब दूसरे लम्हे एक tachycardia हो गया एक topic के साथ. That's atrial tachycardia and re-entrant tachycardia. So focal automatic tachycardia can just start like that, and then re-entrant can also start like that. ठीक है, that helps कि ये sinus tachycardia से deal कर रहे हैं या atrial tachycardia से deal कर रहे हैं. Change in the PR interval at the beginning or the first beat of the tachycardia will tell you whether this is some form of node-dependent re-entry fast slow pathway tachycardia or change in the QRS morphology or variation in the cycle length. So onset जब शुरू हो रहा होता है उस वक्त ये चीजें आपने नोट करनी है. How does it happen? तो PR interval अगर change हुआ है, पहली वाली बीट के अंदर नॉर्मल था और दूसरी वाली बीट के अंदर फास्ट था. I'll show you this. So you have a sinus rhythm here. This is a Holter. This is an ectopic, atrial ectopic, PR normal, sinus beat, ectopic, and then this is a tachycardia which starts with this beat, right? So this is the first beat of the tachycardia. What has happened to the PR interval? So there's a huge change in the PR interval as compared to the PR interval in the previous वाली topic के अंदर. अगर ये short PR interval है और ये fast pathway से जा रहा है तो ये कहाँ से जा रहा है? Slow pathway से. और इसके अंदर जो QRS है वो के अंदर P wave कहाँ छुपी हुई है? ये रही. So pseudo R and a pseudo S in a Holter monitor. So how does this tachycardia start? So you have three things here. You have sinus rhythm ectopics, you have a tachycardia, and you have this transition zone where you see a atrial ectopic starting the tachycardia with a long PR. The tachycardia is a regular, narrow, complex, short RP tachycardia. ये बता सकते हैं इस ECG के ऊपर, इस Holter के ऊपर या नहीं? इस होल्टर स्ट्रिप के ऊपर टैकीकार्डिया की ऑनसेट और टैकीकार्डिया को कैसे डिस्क्राइब करेंगे? ए नैरो कॉम्प्लेक्स रेगुलर टैकीकार्डिया, शॉर्ट आरपी, इनिशिएटिंग विद द पीएसी विद अ लॉन्ग पीआर इंटरवल, राइट? और हमें पता है कि एवियन आरटी के अंदर एक पाथवे ब्लॉक होता है, दूसरा जाता है और फिर टैकीकार्डिया शुरू होता है. ठीक है, सो दिस इज हाउ एन एवियन आरटी विल, क्लासिक एवियन आरटी विल स्टार्ट. चेंज इन पीआर इंटरवल. दूसरा, चेंज इन द क्यूआरएस मॉर्फोलॉजी. एक पेशेंट को प्री एक्साइटेशन चलती है एंड अचानक से एक पीएसी आती है और वो नैरो क्यूआरएस टैकीकार्डिया में चला जाता है. व्हाट हैपेंड? एंटीग्रेडरी जो प्री एक्साइटेशन हो रही थी वो ब्लॉक हो गई, एवी नोड के थ्रू गया और रेट्रोग्रेड अब उसको एक्सेसरी पाथवे मिल गया. सो इट मेड अ सर्किट. ठीक है, सो दिस इज हाउ an AVRT will start if there is a manifest pre-excitation. This may not happen all the time. You may not see a loss of QRS morphology pattern change. You may just see a PAC starting a tachycardia without a change in PR interval, right? So this, if you see, it helps. You may not see it all the time. So do not overthink कि जी ये हो रहा होगा. What you see, just describe that and think of that. Narrow complex regular short RP tachycardia. That's it, right? Atrial tachycardia के अंदर usually wobble होता है. एक P wave आ रही है, दूसरी P wave आ रही है, PP change हो रहा है, थोड़ा सा irregular है before it becomes regular. So that change in the PP interval, which is driving the tachycardia, is called as wobble in the atrial cycle length before it becomes fixed. Re-entrant tachycardia के अंदर wobble नहीं होता. ठीक है, so ये, if you look at this ECG, you have a sinus rhythm non-conducted, and you have another sinus rhythm, and then this tachycardia starts, which is slightly irregular at first and then becomes regular. ठीक है, so this is how an atrial tachycardia will start. And if you see, this is a long RP tachycardia, right? This is R and P is long. So this is a long RP tachycardia, and that is why atrial tachycardia will be the first differential diagnosis. Okay. So once we have looked at the onset, termination can be seen in two ways. Spontaneous हो गया, आप पहुंचे, आपके सामने terminate हो गया, या you have given a drug. So termination अगर spontaneous आपको मिल जाती है, that will only help if the last terminated signal is a P wave. That will tell you that this is an AV node dependent tachycardia. क्योंकि एट्रियल टैकीकार्डिया और AV नोड दोनों एक साथ ब्लॉक नहीं हो सकते. So look for the hidden P waves in the spontaneous termination. You may not be very lucky all the time to see a spontaneous termination ending on a P wave, but if you see it, you can be very, very sure of what the diagnosis is. If it spontaneously terminates on a QRS, you're not wiser anymore, right? But so this is how a termination happens. एक patient है, उसको ये narrow complex long RP tachycardia चल रहा है, ये खुद से terminate हो गया. This is spontaneous termination and patient is back in sinus rhythm. How did it terminate it? Terminated on a, what is the last signal on the tachycardia? It's a QRS, right? So it terminated on a QRS. There's no P wave here, जो कि ये पीछे वाली आ रही थी. So the last signal is a QRS. When it terminates on a QRS, it can still be an AV RT, it can still be an atrial tachycardia. So you will need more information. This spontaneous termination did not help you. This is a termination, another termination. This is a narrow complex, regular, short RP tachycardia, spontaneously terminates on this blip, right? This is a blip here, जो कि यहाँ नहीं है sinus rhythm के अंदर. तो ये क्या हुआ? It terminates on what? It terminates on a P wave, and it has to be an AVNRT or AVRT. It cannot be an atrial tachycardia. So you can say this is a short RP tachycardia, very unlikely to be an atrial tachycardia. It has to be a node-dependent tachycardia. That's a spontaneous termination. When you are in tachycardia and it is not spontaneously terminating, you do maneuvers to differentiate. And the maneuvers are to terminate the tachycardia or slow down the tachycardia to see what is happening. So it is diagnostic and it is therapeutic. Carotid sinus massage is a class 1 indication in regular tachycardia or adenosine. Okay? So there can be 4 possible response of carotid sinus massage or adenosine, right? Either it terminates the tachycardia. आपने drug दिया, tachycardia terminate हुआ, sinus rhythm में वापस आ गया. What does that mean? This is a node dependent tachycardia, and your regular narrow complex short RP tachycardia is either typical AVNRT or orthodromic AVRT. You're still left with 2 differential diagnoses. If it does not terminate but only slows down the ventricular rate and you see persistent P waves happening, then what is your diagnosis? Atrial tachycardia, right? So there can be 2 other possible responses. Either it slows down and then gradually builds up. That is how a sinus tachycardia will behave. आपने drug दिया, 180 से 170 से heart rate, 160, 150, 140, 130, 110, then again 140. That is a gradual decline, and again, this is not termination. That's sinus tachycardia. And sometimes you're giving drug and it is doing nothing. दिए जा रहे हैं. So there can be only 2 things happening. Either the drug delivery is inadequate or it's not a SVT or a node-dependent tachycardia, it's a VT. Fascicular VT can appear very narrow. ठीक है, drug delivery ठीक नहीं है, carotid massage ठीक नहीं है, anything can happen. ठीक है, so ये कहेंगे जी कुछ ही नहीं हुआ, कुछ हुआ ही नहीं. That does not mean कुछ नहीं हुआ. You still have to have an answer for that. कि जी कुछ नहीं हुआ means that nothing happened to the tachycardia. This is probably not SVT, this is a VT, right? So these are the 4 responses. In tachycardia, you have this AVNRT terminates, right? And here you don't have to look for P wave or QRSs. That is a spontaneous termination that you want to look for. कि P है या QRS है. ये तो ड्रग का इफेक्ट है ना, tachycardia टर्मिनेट हुआ या नहीं हुआ. अब वो P पे टर्मिनेट हो या QRS है, उसकी मर्जी है. ठीक है, we not concerned about that. We only concerned कि वो टर्मिनेट हुआ या नहीं हुआ. AVNRT और orthodromic AVRT टर्मिनेट हो गए. Atrial tachycardia के साथ क्या हुआ? Ventricular rate slow down हो गया क्योंकि AV node को ब्लॉक किया, लेकिन atrial tachycardia जो चल रहा था वो अपनी जगह पे चलता रहा. This is a focal atrial tachycardia. ये क्या है? You are able to see more P waves, and this is also in atrial tachycardia, which is a macro reentrant atrial tachycardia. This is how a tachycardia will behave. Only AV node will slow down, but the tachycardia will not terminate. So we have 10 minutes and we have few cases. Do we have any questions from the participants? Bhavalpur, Hyderabad, Jamshoro, anyone? Do we have any questions? No? Okay, so 45-year-old lady, palpitations for many years, sudden onset and sudden offset on the history. This is the ECG. So you have a 12-lead ECG. Fortunately, you have sinus rhythm on one side and a tachycardia on the one side. Take it, and then you have a transition zone here. सही है? तो आप इस ECG को कैसे पढ़ेंगे? On the right hand side there is sinus rhythm and PAC. On the left hand side there is a tachycardia. This tachycardia is regular, narrow, complex, long RP tachycardia, which spontaneously terminates to sinus rhythm on a QRS. My differential diagnosis is atrial tachycardia versus atypical AVNRT. ठीक है? So narrow complex regular tachycardia, AVNRT, AVRT, atrial tachycardia, sinus tachycardia, right? This is what it is. We have some questions here. Is it atypical AVNRT? Is it atrial tachycardia? Is it sinus tachycardia? Is it none of the above, all of the above, and only atypical AVNRT and atrial tachycardia? 1 and 2. Why is it not sinus tachycardia? It is a long RP tachycardia. Why is it not sinus tachycardia? Why is it not a sinus tachycardia? Long RP के अंदर. Abrupt termination. Termination तो आपको कुछ help नहीं कर रही है ना, यहाँ बता दिया. वो atrial tachycardia. Why is this not sinus tachycardia? Any smart people, participants में से कोई है? हाँ? So in sinus tachycardia, the P wave should look like a sinus P wave. It has to be positive in lead 2, 3 AVF, negative in AVR. How can a sinus tachycardia be negative in inferior leads? Common sense means common understanding of common things. Sinus beat P wave always positive in lead 2, 3 AVF and negative in AVR. This is negative in lead 2. This long RP cannot be sinus tachycardia. This is either AV and RT, atypical, or an atrial tachycardia. Another patient, 14-year-old, palpitations. So you have, again, very lucky to have a 3-lead kind of a rhythm strip. You have sinus rhythm here, and you have a tachycardia here. ठीक है? So tachycardia को कैसे पढ़ेंगे? Regular, narrow, complex, short RP tachycardia. Differential diagnosis क्या है? AVNRT, AVRT, or atrial tachycardia. Since you have an onset here, that will help you कि ये कैसे on हो रहा है. क्या ये wobble के साथ हो रहा है? क्या QRS की morphology change होके हो रहा है? या PR की change के साथ आ रहा है? So if you look at this, साइनस के अंदर PR शॉर्ट है. ये एक टॉपिक बीट आई है जिसको लॉन्ग PR के साथ कंडक्ट किया और टैकीकार्डिया स्टार्ट हुआ. So this onset gives you one clue. In a short RP, 3 differentials में से what is the possible diagnosis here? So ये तीनों possible हो सकते हैं अगर मैंने आपको सिर्फ ECG के ऊपर ये narrow complex short RP tachycardia दिखाया होता. But when you see an onset which starts with a long PR from an ectopic beat, usually this is an atypical, it's a typical AVNRT onset, long short. So this is a typical AVNRT. Another 20-year-old palpitations. This is also a narrow complex regular tachycardia. You have one P wave to each QRS. You analyze the RP, which is short, then PR. What are your differential diagnoses? Typical AVNRT, AVRT, or atrial tachycardia. Now, when you are in a tachycardia, so these are all three possible differential diagnoses of a short RP tachycardia, right? Now, what are you going to do next? You're going to do carotid massage, digoxin, or shock. You're going to do a carotid sinus massage, and what do you expect? Why are you doing this? You are looking for either termination or slowing down of the conduction, and you want to have a diagnosis, whether this is an atrial tachycardia or a node dependent tachycardia, right? That is what your understanding is. ये इसलिए दे रहे हैं कि मुझे ये पता चले कि इन तीन में से कौन सा एक या दो है, right? So the tachycardia terminates to a sinus rhythm, so its atrial tachycardia is out. What happens? The patient is in sinus rhythm with pre-excitation, right? So what is the diagnosis now? So orthodromic AVRT to hai, but since you see a sinus rhythm with a WPW, it is a manifest pathway, right? So it is orthodromic AVRT with manifest accessory pathway. Thirty lady, peripartum cardiomyopathy, presents with palpitations, right? So what is happening? Narrow complex, regular tachycardia. Do you see P waves? Do you see more P waves than QRS? So what is it? Atrial tachycardia. So this is an atrial tachycardia, AVNRT, orthodromic AVRT, atrial fibrillation और MAT. इन पांच में से क्या है? ठीक है? So you looked at the ECG, tachycardia, you looked at the P waves, you look at the regularity, and then you come with one diagnosis without even looking at the possible differential, because this has to be atrial tachycardia. It cannot be anything else, right? Okay, 50-year-old palpitations. This is what is happening. So what is happening here? This is a tachycardia, narrow complex tachycardia. It is regular, right? Do you see P waves? Where are the P waves? Just after the QRS hidden. Are there more P waves than QRS, or equal number of QRS P waves? Equal number of QRS. What is the RP? Short RP. What are the possible differential diagnoses? Okay, so three differential diagnoses, all of them, right? But short RP में AVNRT पहले, AVRT बाद में, और फिर आखिरी में atrial tachycardia with first degree AV block. What is the next step? You do a carotid massage or a adenosine. And what are you expecting? You expect termination, and that is what is happening here. So you have a strip where you see tachycardia, adenosine, terminates, and then it starts again. But this is a clean, it terminates. Okay, so what is happening here? What are the possible differential diagnoses? 1 and 2, this is a node-dependent tachycardia because it terminated to sinus rhythm. It did not slow down. You did not see more P waves, right? So orthodromic AVRT or atrial AVNRT. 20-year-old has a Holter. And Holter पे हमें बहुत सारे tachycardias मिल जाते हैं. So this is sinus rhythm and this is tachycardia. So this tachycardia is what? Regular, narrow, complex tachycardia, and you see one P wave to one QRS. So this is a short RP tachycardia. So short RP tachycardia की ऑनसेट कैसे हो रही है यहाँ पे? एक पीएसी आ रही है, बट पीएसी के साथ व्हाट इज हैपनिंग? PR interval is almost the same as the previous PR. There's no jump, no change, no first degree AV block. One PAC has started this tachycardia, which is a short RP tachycardia, right? You have this body of tachycardia and you're going to describe this as regular, narrow, complex, short RP tachycardia. And you've seen the onset without a jump. And it spontaneously terminates on what? Do you see a P wave here? No, you see a spontaneous termination to a QRS. So does this help you? No. So what are the possible differential diagnoses? All of them, right? All of them can still happen. Okay, so finally you have to take some take home messages. I hope कि ये ECG आप लोगों के लिए session फायदेमंद था. This is broad categorization: regular, irregular, narrow complex tachycardia. बाद में ढूंढें P wave आ रही है या नहीं आ रही है, fibrillatory. First look at the RR interval regularity before you start describing anything. Fundamentals of SVT diagnosis: you have to analyze the body, look for P waves, presence of a number of P waves, look for the QRS के अंदर hidden P waves, analyze the RP interval, look for the onset कि उसमें कैसे हो रहा है, PR change हो रहा है नहीं हो रहा, QRS morphology change हो रही है नहीं हो रही है, wobble हो रहा है या नहीं हो रहा है, ये आपको सब help करता है. Spontaneous termination helps you if it terminates on a P wave. Diagnostic and therapeutic use of adenosine to differentiate between node-dependent tachycardia or atrial tachycardia. Okay, so here we finish. Okay, so do we have any questions from our participants? Kashif, Usama, आप लोगों की टीम में से? कुछ समझ आया या नहीं? Any questions?
Do you hear?
Yes, I am here.
Yes, madam, how you can differentiate long PR interval to atypical AVNRT and AVRT, long PR interval? How can you differentiate it? Any point you can differentiate it?
I'm sorry, can you please repeat the question? आप प्लीज अपना क्वेश्चन रिपीट कर दें, क्या कह रहे हैं? एटिपिकल AVNRT और atypical AVNRT is a long RP tachycardia, and usually AVRTs are not long.
Or AVRT in long PR interval.
Long RP में usually AVRTs नहीं होते हैं differential diagnosis में. AVRTs are all short RP tachycardia. Long RP में atrial tachycardia और AVNRT होते हैं atypical, और उसको आप differentiate कर सकते हैं with adenosine.
Madam, I am Dr. Noman from Cardiac Center, Bahawalpur.
जी बोलिए Noman.
हाँ, so I am assistant professor here, and our team is very grateful for your very good presentation. And for our trainees and juniors, it is a very nice presentation, and we all thankful for you for this effort.
Thank you so
very much, madam.
Thank you. I hope you have learned something from this session.
Yeah, it's very very useful and very good point for all the trainees and pages.
Thank you. काशिफ, आपके
Thank you very much.
किसी को कोई क्वेश्चन है?
Yeah. Do you hear us?
जी जी, काशिफ, I can hear you.
I feel it was.
Yeah, I feel it was.
बंद करो. हाँ, अब वहाँ से.
We can't hear you clearly. Okay, guys, you can go. Thank you. Okay, so we're going to end the session here. And when we have a next session, we'll let you know in advance.
With the voice.
Ji Kashif.
Yeah, thank you very much, Fariha, for this nice presentation. I believe this shall be a very helpful for our fellows. And definitely we being the interventional cardiologists are not very deeply into the electrophysiology and ECG kind of things. But I personally believe your presentation was very precise, point, practical, and I personally very much useful for our fellows as well in future. And we will keep in touch, inshallah. Thank you very much.
Inshallah.
And
thank you very much, guys, and thank you for joining. Inshallah, we'll keep in touch. Recording off.
that's all. Take care of yourself.